position again, because again, we want to utilize the weight-bearing capabilities to normalize the tone. So, you know, we can have her hand, her arm in that position, have her feet on the floor. What would you think that the position of, and again, this is going to be her affected side, what would you think that the position of the foot would be in to indicate that there might be increased tone?
Internal.
Plantar flexion. Inversion.
Okay, plantar flexion is part of the extensor synergy pattern, correct? What about dorsiflexion? Is that part of any synergy pattern?
I don't think so, yeah.
It's part of the flexor synergy pattern. So you can't tell, okay? What is the common denominator for the ankle for both the flexor and the extensor synergy pattern?
Inversion.
Inversion or supination, correct? So we're going to look at her normal side, okay, which you can see, some people will not have any arch at all, so they'll be really pronated. Other people will have a high arch, so you're going to compare it with the good side, okay, and see what she's got. So the position of her foot to indicate that she has increased tone would be like that, correct? Okay, so if we look at the foot like that and you try and put it down and you can't, it's just kind of stuck there, then you know that the patient has increased tone in supination and we need to mobilize. Okay? So, a couple different ways you can do it. If you like to go down on the floor, again, you can, I'm just going to move this chair back just a little bit.
Yeah, here we go, so no worries.
You can take, and again, you're going to be using the same kind of grasp that you used with the hand, because I don't want to put pressure on the bottom of the foot or the sole of the foot. Why? What happens if I put pressure on the ball of the foot? It'll go into plantar flexion and rigid extension of the whole leg. So I want to avoid that. So I'm going to keep her heel in contact with the floor because I want the weight-bearing component. But I'm going to put my hands on either side of her foot. Okay? So similar to what we did with the hand. Again, my thumbs are going to go on her metatarsals because I want to stretch the intrinsic muscles. So I'm going to, not down here, I want all the way along the metatarsals. And I'm just going to be putting pressure up and down. Actually, more pressure going down into pronation than coming up into supination. But up and down with my thumbs on her metatarsals. And I'm going to work my way along. And do it as slowly as you can.
How long do you normally do this for, Sue?
Until you can get the foot to look similar to the other one. Okay? Now, sometimes I see patients who have had a stroke and it's been a period of time, and I will go to transfer them or stand them up, and their foot will be in this position, and they can't get it flat. I don't really want to stand a patient on a foot like that, and so I'll do a lot of the mobilization. But if it's been several months or maybe even a year or so after their stroke, I may not be able to get the foot entirely flat like the other one. But I'll take that into account, and I won't be spending a whole lot of time doing walking on that patient because they aren't able to then get the foot flat for stance. Okay? But if you have a patient who you start working on and it's only been a few days after the stroke and they're starting to get some spasticity and you want to get rid of the spasticity,